Welcome all of you to the CME series of Agarwal Eye Hospital Clinical Board and Education Committee. This is the Flavor of the Month 36th series. In this series, we have a couple of topics on pediatric ophthalmology. First will be, our speaker, Dr. Padma Priya, who is a pediatric ophthalmologist and squint surgeon. Right now, she is in the Sholinganallur branch of Agarwal Eye Hospital. A little, intro about her. She has done her MBBS in Vinayaka Mission Medical College, and she has done her DO in RIOGOH in Madras Medical College, Chennai, and she's done her DNB in Rajan Eye Hospital and done pediatric ophthalmology fellowship in our Agarwal Eye Hospital. First, she will be talking about pediatric refractive error correction, following with me, Dr. Akshya, who is right now in pediatric ophthalmologist in CMH Chennai, will be talking about myopia controls. I think we can get started. Over to you, Dr. Padma.
Thank you for the sweet intro, Dr. Akshya. So good evening, everyone. Myself, Dr. Padma Priya. I'm a pediatric and squint consultant at Dr. Agarwal's Eye Hospital, currently at Shoringanallur. I'll be talking on pediatric refractive error management. This is an often discussed topic, but it is highly evolving. So this session is likely to update ourselves. So let's get into the topic. First, let's see the prevalence report of pediatric refractive error in India. So this is a systematic review which says that per 100 children, the prevalence was 8. And in school-going children, it is 10.8, of which myopia was 5.3%, hyperopia of more than 2D was 4%, and astigmatism was 5.4% respectively. We all know what a normal vision is, where the parallel light of rays, they get focused onto the retina with accommodation at rest. And when this doesn't happen, we can see the most common refractive errors happening. So let's discuss about them and their management. So the myopia management, recently the trend has shifted from a mere myopia treatment to myopia control and management strategy. Let's see why this has happened. So according to a AAO survey, they have realized that childhood myopia is on the rise. The myopia prevalence was 2.6 billion in 2020 and was estimated to double to 4.8 billion by 2050, which is an exponential rise in just 30 years. So imagine this much of prevalence happening in 2050. And we can also see that the myopia risk. So what's the risk associated with myopia progression is that as the number increases, we can see more number of ocular complications associated with it. So when the power is more than -6, we can see a 5 times increase in glaucoma, 14 times increase in cataract, 22 times increase in RD, and 41 times risk of having a myopic maculopathy. So hence the emphasis and significance of controlling the myopia progression. Now myopia control has become a specific targeted approach which broadly fits into these 5 arms, and they are lifestyle modifications, orthokeratology, multifocal soft contact lenses, atropine eye drops, and multifocal spectacles. Except for lifestyle modifications, all the rest work on modifying the axial length elongation of the eyeball. Moving on to lifestyle modifications, we have modifiable and non-modifiable factors. The non-modifiable factors is the gender and the genetics. Gender, where according to Comet study, it says that females are at the risk of myopic progression, especially at the time of menarche. And when coming to genetics, we know that the risk is very low for a child to develop myopia when neither of the parent is myopic. It is a threefold risk when one of the parent is myopic and 6 times risk when both the parents are myopic. According to Cream study, it finds out what is the genetic significance of myopia, and they have come to find out that the risk of developing myopia is multifactorial and it cannot be relied on one single underlying cause. Coming to modifiable risk factors, they are basically the environmental risk factors, where outdoor activities and outdoor sports, they are inversely proportional to myopia progression, and near work and poor illumination, they are directly proportionate to myopia progression. There is a significant odds ratio of increase of 2% of myopia for every diopter hour increase in near work per week. So what do we choose from? There are various modalities of treatment available, right from spectacles to refractive error surgeries. There are many modalities available. So let's look into each one of them. The glasses, they are the gold standard. The single vision glasses, they are best suitable for non-progressive myopes, simple and compound myopic astigmatism, and myopes with muscle imbalance like phorias and tropias. The concept of myopia treatment to myopia control works well for axial myopia, whereas non-axial myopes like lenticular myopia, curvature myopia, syndromic myopia, and ROP associated myopia, they do not have a effective myopic control. They can be very well treated. Let's get into the etiopathogenesis of axial length elongation and myopic progression. So this is we see the black line, they are parallel rays of light, and from the central direct rays of light, they get focused onto the retina. But look into what happens to the peripheral light rays. The peripheral light rays, the retina being a curvature structure, they get either focused in front of the retina, bringing about a myopic defocus, or are focused behind the retina, resulting in a hyperopic defocus. This hyperopic defocus is a stimulant for axial length elongation and thereby resulting in myopic progression. So this is the basis for axial length elongation and myopic progression. So what happens with a single vision standard lens is that the central rays of light, they get focused onto the retina. But what happens to the peripheral rays is that they are focused behind the retina, resulting in a hyperopic defocus, which is a stimulant for axial length elongation and myopic progression. So standard lenses, they are an effective treatment modality for myopia, but not for control of myopia. So now peripheral defocus lenses have evolved to bring this myopia control. So let's look into that geometry of peripheral defocus lenses. They have a central clear zone. So this zone has the myopic power to correct that particular myopia. So through which the central rays, when focused, they get focused onto the retina. But what happens surrounding this clear zone, there are small multiple plus lens integrated small segments. So these are called as DIMS, that is defocus integrated multiple segments, which are present surrounding the clear zone. So when as light rays pass through them, they are focused in front of the retina. So this DIMS segments, what they do is they bring a shift from hyperopic defocus to myopic defocus. Thus, the hyperopic defocus, the stimulant for axial length elongation and myopia progression is halted. So this is the basis for all the myopia control lenses that are available in the market. For example, the MyoSmart lenses of Hoya and Stellet lenses of Essilor. I would like to present how a clear view will be like when seen through a single vision glasses, and this is through a myopia control glasses where you see a effective crisp and clear central zone, but there is a slight peripheral myopic defocus happening, but the children do very well get adapted to it, and there is no big problem with that. So RCT studies have demonstrated that DIMS lenses bring about a 52% less in myopia progression when compared to wearing single vision lenses. So moving on to axial length. Why is axial length measurement important? I would like to say it is not mandatory, but it is helpful in measuring the axial length. One, to note down and confirm whether it is an axial myopia. Second one, to document the axial length and review for myopic progression and axial length elongation in review visits. Third point, if at all we have started the child on myopic control, any treatment modalities, to look into the efficacy of that particular modality, and if progression still continues with that modality, then we can look into other treatment options to combine with them. So these all can happen if we document the axial length properly. So now we have this LensStar myopia suit available where it incorporates a myopia software through which we will be able to see about the age matched myopia, axial length curves, refraction and environmental factors that affect for that particular child. And it also gives a probability of how much the power can escalate to with various treatment modalities for that particular child when the child is around 17 to 18 years of age. So with this software, we can come to a conclusion what kind of a therapy will be helpful for the child. If this sophisticated software is not available, all that requires is documenting the axial length with the IOL master or with a simple A-scan biometry. Now moving on to orthokeratology. So what is orthokeratology? So it is a specifically designed RGP lenses that are worn during sleep. So what happens during sleep? It temporarily alters the corneal shape in such a way that the myopia power is negated. So what happens in the morning? The child doesn't have any power and need not wear any glasses or contact lenses. So this is how Ortho-K treats the myopia. So here we can see that this is the corneal map before fitting the Ortho-K lenses, and this is the reshaping that is happening after the fit. So here we can see that the central cornea is flattened. So this flattening negates the myopic power. But what this is also an effective modality to control myopia, and how that happens is this paracentral zone that we see here adjacent to the central zone. So what happens here, these lenses have a special geometry called as the reverse geometry, which creates a negative pull force. So this results in steepening of the cornea at this particular portion, which we can see as a red circle mark in this topography map. So with this, what happens? The peripheral rays gets a myopic defocus, thereby halting myopia progression and axial length elongation. So this is the lens model where we see a vision correcting central zone surrounded by this. The paracentral area is the myopia control, reverse curve zone. Then we have the lens stabilizing zone followed by the peripheral zone for tear exchange. Earlier it was used for myopia treatment. Now they have found that myopia control also happens very well with orthokeratology. So now the center optic zone has been remodulated so that it fits into the myopia control design. So the usual lenses, they are about 6 to 6.8 mm, the center optic zone. But when it comes to myopia control with orthokeratology, the central optic zone is redefined to make it very smaller to 5.4 mm so that the peripheral aberrations are aborted, and also to bring about an effective myopic control. Moving on to multifocal soft contact lenses. Daily disposable soft contact lenses, they are used as a treatment option but not as a control option, whereas multifocal soft contact lenses, they are both a treatment option and a control option. There are various products available in the market like Coopervision MySight Day 1, Ability Day 1. They are available as daily disposable lenses and also monthly disposable lenses. So what happens in them is that they have simultaneous defocus, where there is a central correction zone which treats myopia, followed by concentric treatment zones where there is a +2 addition. So these concentric zones, they bring about a myopic defocus, thereby controlling myopia progression. So these are like IOL, they have even EDOF models also, and they have a center distance contact lenses also. So these are the various models available, of which I believe MySight and Ability is available in India. The rest are not available in market in India. So this is the graph which shows that after 3 years studies, when compared with the single vision daily disposable contact lenses, they found out that there is a 59% less myopic progression with MySight and 52% less axial length elongation with MySight. Moving on to pharmacological agents, atropine. So it is a widely used and researched drug when it comes to myopia control. So it is a non-selective muscarinic receptor antagonist. And pyrazipine, it is a selective M1 muscarinic receptor antagonist, but now currently not used for treatment. And the 7-methylxanthine, this is something, the treatment modality is carried out only in Denmark, and it is a oral drug being administered for myopia control. So the students over there, they get about 400 milligram oral dose every single day, was found to be effective. Atropine and pyrazipine, they both work with, inhibiting scleral proliferation. Whereas 7-methylxanthine, they modulate the scleral collagen fibers and result in choroidal thickness, thereby inhibiting scleral proliferation. So these are the pharmacological agents that are being used. And we have this famous atom study for atropine, where they found out from the atom 1 phase that atropine 1% is very effective in controlling myopia, but it has a very profound rebound phenomenon. So they switched over to atom 2 phase 1, where among different concentrations, they found out that atropine 0.01% is really very effective in controlling myopia and less rebound phenomenon with it. And so they had a 5-year clinical study with low dose atropine of 0.01%, where they found out that this particular concentration slowed down myopia progression by 50%. So this is about the ATOM study. And the LAMP study is a recent study where various low dose concentrations like 0.05%, 0.025%, and 0.01 formulations were compared and found out that 0.05% is very effective among all the three. So currently using atropine, we give them as once daily dosage, especially at bedtime, for about 2 to 2.5 years. And then when we document that there is no further myopic progression or axial length elongation, then we gradually taper them. So this is how atropine dosage has been done now currently. So new in the block is this RL therapy. So currently not available in India. So this is repeated low level red light therapy. So it brings about a photobiomodulation where it works at the cellular level, modifying gene expression, thereby bringing about a scleral remodeling, inhibiting axial elongation and myopia progression. So here a 650 nanometer red light is used to slow down progression. It is also found to enhance blood flow and choroidal thickness. It can be used as adjunct to other therapies also. The next is this DOTS technology. We found that the earlier myopia control glasses, they used peripheral defocus, but these glasses, they use diffusion optics technology. So here the funda is that high retinal contrast signals, they induce eye growth. So here what happens, there is a central clear aperture followed by multiple small light scattering dots which reduce the retinal contrast sensitivity, thereby doesn't allow axial length to elongate and thereby inhibiting myopia progression. This is called as diffusion optics technology. This is also currently not available in India. So how do we gauge success? It is by noting down the power, refraction power. So if it is more than minus 0.5 D per year, then it means that there is a myopic progression happening. Then we have to look into it. And also the axial length change. The annual axial length change for a normal child is between 0.1 to 0.2 mm, and anything above 0.2 mm shows that there is a progressive axial length elongation and needs a treatment modality. So when we find that one control modality doesn't work, then we can very well go in for a combination therapy where there are various permutations and combinations available, where orthokeratology can be combined with low dose atropine. Multifocal contact lenses can be combined with atropine, and DIMS glasses, the spectacles, myopia control spectacles, they can also be combined with low dose atropine. First, it is usually a single modality treatment, and if it fails, then we can go in for a combination therapy. So this is the myopia consensus statement of 2025 released by World Society of Pediatric Ophthalmology and Strabismus. It is of course available online. So I would like to help and highlight on what does not work for myopia control, and it shows that undercorrection, pinhole glasses, blue light blocking glasses, bifocal glasses, progressive glasses, daytime single vision soft contact lenses, RGP lenses, and progressive glasses used to reduce lag of accommodation during near work. All this definitely do not have a role in myopia control and progression. But what appears to work is increased time spent outdoors, reduced time on near tasks like smartphones and digital devices, and also reading, and the other optical treatments that we have discussed before. So this is in short about myopia management and control. Now moving on to hyperopia management. See, the options available are glasses, contact lenses, refractive surgery, though not a preferred choice for pediatric age group. I would like to emphasize on one point why hyperopic patients accept undercorrection. So this is because the accommodation comes into play. What happens in hyperopia? The rays get focused behind the retina. So this acts as a stimulant for accommodation, and accommodation comes into play, to compensate that. So what happens when there is an actual power of 5D, the patient, even with a 3D plus 3D lens that is being undercorrected, can still read 6.6 because the accommodation comes into play and it compensate for the refractive error. So thereby, even with a plus 3D lens, the child can read 6.6. but that doesn't mean you have to give them a plus 3D lens. What happens eventually over a long period of time, this undue accommodation can result in asthenopic symptoms or accommodation. So always, if it is hyperopia, please do not undercorrect. Look into for cycloplegic refraction and give them the maximum plus to make the patient comfortable. So the fundamental rules in hyperopic prescription is that always do a cycloplegic refraction followed by fogging in PMT visit. The patient should be given the maximum subjective acceptance, and if it is a esophoria or a tropia, full correction needs to be given. Initially, the child may not read 6-6 with that plus 5 full hyperopic correction. If even then, it needs to be given somewhere close to that number so that the child doesn't develop asthenopic symptoms in future. Moving on to astigmatism, we all know what astigmatism is. So the main, management therapy is either wearing glasses or toric contact lenses. The toric contact lenses are not a great choice for pediatric population. Now moving on to some pearls in giving astigmatism prescription is that never undercorrect. We need to give the full correction because kids do accept full correction. There is no need for any under correction of astigmatism for a pediatric age group. And also say the child has a minus 2.5 diopter of astigmatism. Under correcting it will lead to amblyopia because that minus 2.5 the astigmatic power, it is an amblyogenic power. And always give the prescription when there is a difference in astigmatism between both the eyes of about 1.5D or more than that. Always see to that you refine the axis. Patients with against the rule astigmatism, they are more symptomatic than with the rule astigmatism. And always do a slit lamp examination to rule out any corneal or ocular pathologies in case of irregular astigmatism. Irregular astigmatism also needs ruling out keratoconus by appropriate investigations like topo or pentacam. Also, for pediatric population, look into the proper fit of the frame because any slight tilt in the frame can alter the axis and result in vision distortion. And also see that there are no abrasions in the lenses because when viewing through these aberrations, then it doesn't justify, a clear vision for those children. So this is the AAO guidelines available in web for refractive corrections in infants and young children. So it gives a detailed description of what power needs to be corrected at what age with strabismus and without strabismus. So you can quickly go through it to get an idea of how to correct for infants and children. So when it comes to managing pediatric error, management, refractive error management, amblyopia becomes a part and parcel of it. So the first role will be always giving them glasses, and that needs to be worn full time. For some children, glasses along with patching may be required. We can give them daily disposable contact lenses, especially for pediatric population, if it is a high unilateral power to prevent amblyopia and also to prevent spectacle related anisoconia or spherical aberrations that can happen with a high power. So these contact lenses, they could be daily disposable soft contact lenses, or there could be a combination of both. Contact lenses and spectacles can be given in case there is a combined high power like high spherical and high astigmatic power, where the spherical power can be dispensed as daily disposable soft contact lenses and the astigmatism can be given in the glasses. This is to prevent anisoconia and also spherical aberrations that can happen with high-powered spectacles. So the take-home message would be the common pediatric ocular problem is that of a refractive error. So the responsibility is on us to give them the optimum correction rather than comfortable subjective correction. So this is mainly to prevent amblyopia, asthenopia, and to a certain extent squint also. So do not go by subjective verification in young kids. Always we need to rely on objective verification while giving glass prescription. And always please do manual retinoscopy because the kids are unreliable, and preferably it should be a cycloplegic dilated retinoscopy. So retinoscopy always is the gold standard for pediatric refraction. So I thank the clinical board for this opportunity, and I look forward to any doubts or queries regarding this session. Thank you again.
Thank you, Dr. Padma. Thank you for the wonderful session. That was an elaborate session on the pediatric refractive error management. I think I will finish my talk because mine is going to be very simple. Dr. Padma has covered it all. I'm just going to give a summary or a quick revision of whatever she's told on myopia control. And I think we will take up the questions and have a discussion sessions. I think there are a lot of optometrists also here. After my session, let's take up the questions and discuss also. I'm Dr. Akshya, pediatric ophthalmologist. Currently, I'm in the CMH Agarwal Eye Hospital. So I'm going to talk about myopia control. Okay, like Dr. Padma has said, myopia management doesn't end with only correction, which is given for clear vision. Control is an important integral part of myopia management. So it's correction and control. So control will be first and foremost lifestyle changes, optical measures, eye drops, and a combination of these things. So in correction, like Dr. Padma has told you, you can give glasses or contact lenses. These are generally only a single vision glasses or single vision contact lenses. So why do we talk about control of myopia? Again, this is going to be a reiteration of whatever she's told. Very important, when there's an increase in 1 diopter of myopia, the increase in risk of myopic maculopathy, which is going to be sight threatening, is about 67%. So as the error of refraction increases, like if 6 diopters and more, the chance of a posterior subcapsular cataract is times more. So retinal detachment is 21 times more and myopic maculopathy is 41 times more. The main reason to control that rate of growth of eyeball is to avoid high myopia and its related complications. Just to tell you all that I think we all know that the axial myopia or myopia in childhood is because of an accelerated rate of growth of eyeball, which we are trying to control by means of the control measures. We need to understand myopia control measure using 3 fundamental characters. One thing is the outdoor time in daylight. Second is axial length. Axial length is actually a very, very key factor for myopia control, more than refractive error, because you have to establish an axial myopia first to know it's going to progress. And axial length is the thing that you're actually trying to control. And very important, which we all miss, is binocular vision anomalies. Any kind of binocular vision anomaly, if left untreated, will lead to progressive myopia. So we have to remember about the importance of outdoor daytime, axial length, and the binocular vision problems. Outdoor, why is outdoor more important? 2 things. One is whenever we are in an indoor environment, okay, about less than 3 meters, there is always a blur in the inferior retina, which is a hyperopic blur. Whenever there is a hyperopic blur in the center or in the periphery of the retina, that is a stimulus for the growing eyeball to grow faster. So an indoor environment is going to keep providing that peripheral hyperopic blur. Outdoor environment, of course, it's going to be more than 3 meters in infinity. And the outdoor daylight levels, the sunlight levels are 11 to 43 times more compared to the indoors. And from the studies done before, from the myopic adults, they've all shown lower levels of ocular exposure to UV light. And there is a genetic and an environmental, interaction also, which plays a role in importance of outdoor sunlight. And outdoor is very, very important before the onset of myopia. So it's very important to find a child who is at risk of myopia onset and start of the outdoor daylight exposure. Axial length, when the axial length becomes more than 26 mm, there is 2 to 25 times chance of developing a visual impairment because of cataract by 60 years of age, or 90%. So it is like 25 to 90%, starting from 26 to 30 mm at the age of 75 years. Our goal is to keep the refractive error less than 3 diopters for myopia and axial length less than 26 mm. So that's our target in actually controlling the myopia. About binocular vision problems, what do we exactly mean by that? A lot of myopes have this accommodative lag. Like Dr. Padma had told you, that hyperopes know how to accommodate because they accommodate for distance itself. But myopes, if they try to accommodate, the rays are going to fall even more in front of the retina and it's not going to be of use to them. So they never know how to accommodate. So they have a big accommodative lag. Along with the accommodative lag, you can also have esophoria. If a child has a high AC by A ratio, which is accommodative convergence by accommodation, which is going to lead to esophoria. If the esophoria is there is 30 times chance of myopia progression. Similar with exophoria. If you leave a child undercorrected and exophoric, it is a factor which is going to increase in the progression of myopia. So as far as myopia progression and binocular vision is concerned, lag of accommodation esophoria for near and exophoria are going to be factors which is going to cause progressive myopia, which has to be corrected. And control options, as already told, always single vision with the low dose atropine, bifocal or progressives with low dose atropine. So there is a change in the concept here. Bifocal or progressive glasses in them by themselves are not going to cause control of myopia. They're only going to treat the lag in children who have myopia or esophoria. So if you're going to give them, you also add an LDA. And myopia control glasses, DIMS, HALT, CARE, and DOT. And of course, we're going to give same thing with multifocal contact lenses that we give for the adults for presbyopia. They are also going to treat only the near lag. So if you're going to give multifocal contact lenses, I would suggest you also go for an LDA as a control option, because any progressive glass or multifocal contact lenses is going to take care of your lag, but not your progression. And then of MySight dual focus, basically it has the different plus zones as treatment, and then you have the correction zone in the center. Orthokeratology and the red light therapy as mentioned by Dr. Padma. So lifestyle, quickly I'll tell you what you should tell what you should advise as lifestyle changes. 2-hour rule. So 2 hours of outdoor daylight activity when the sunlight is there. Best time would be in the morning, like 6 to 8, or in the evening, something from 4 to 6 before sunset, preferably with a physical activity. Second, 2-hour rule. After the school, excluding the school time, maximum of 2 hours of, indoor near work of any sort is maximum permissible. Better to take half an hour break. I mean, not to go at a stretch 2 hours, but to take breaks after every half an hour. And even if the child is reading, the book material should be kept at 40 centimeter or the elbow. Approximately the elbow size, elbow length should be maintained from the eye and the book. And after every half an hour of reading or 20 minutes of reading, you encourage the child to look at the far off object for 20 seconds. Far off means 20 feet object for 20 seconds, basically to break that continuous near work. Control by myopia glasses, like already told, generally a myopic eyeball is prolate, meaning the anterior posterior length alone is longer as compared to the equatorial length. So this anterior posterior length is going to keep increasing. So whenever there's an anterior posterior length and increase, and you're going to give a single vision glass, the focus is not going to be uniform on the retina. So the center will have clear focus, but the periphery is going to have a focus which is outside of the eyeball, which is called the hyperopic defocus. And any hyperopic defocus is actually the drive for the growing eyeball to keep growing. So that has to be eliminated for myopia control. Picture which is showing a peripheral hyperopic defocus, and by means of some control measure, the peripheral hyperopic defocus has been eliminated, and the rays are coming inside the eyeball, changing it into a myopic defocus, which is not a stimulus for the eyeball growth. And of course, we have all the elimination of the peripheral hyperopic defocus is being done by the spectacles of different specialized designs, like defocus incorporated multiple segments, where you have the correction zone here and the control zone having a honeycomb pattern of plus lenses. So the range of refractive errors that that this lens, the DIMS Hoya lens or the MyoSmart that can cover is totally 13 diopters and with four diopter cylinder. And they also have this photochromic type which can cover up to 10 diopters. And the other variety of this myopia control lens is highly aspheric lenslet technology, wherein the similar plus lens are in the form of concentric circles here. This also serves to provide a volume of defocus, in front of the retina rather than behind the retina for a myopic eyeball. Here, the total power can be up to 12 diopters with a 4 diopter cylinder. And this is also recommended for pre-myopic children, anisometropic or, antimetropic children, because they also start the small plus. So pre-myopes, I'll come to them. If a child has a lot of risk factors and is a pre-myope, Stellest lens, a HALT technology is better than a DIMS technology. And then next is the CARE technology, which is cylindrical annular refractive elements, as you can see in this picture. This again works, on the principle of the elimination of peripheral hyperopic defocus. So they have a stock ready-made lens of 6 diopters with 2 diopter cylinder, and a prescription lens of 9 diopters with even 6 diopter cylinder. A maximum of even 10 diopters is available in high index. That is about the myopia control glasses. So moving on to the contact lens options for myopia control. Of course, one thing is the multifocal contact lenses, but whenever you give the multifocal contact lenses, make sure you also add on an atropine, which is actually a time-tested method for myopia control. But the actual lens that is going to control myopia, that design is the MySight or a dual focus design. So dual focus design, as you can see in this picture, it has the blue rings are all the treatment zones, which are all the plus segments, which are, if you see in the picture, it's bringing the focus into the retina rather than outside the retina. So here again, you can give up to 10 diopters, and it comes with a single base curve and a diameter. But we are not using this widely as of now, but this is a very good, very effective myopia control measure. And orthokeratology. So orthokeratology is a game changer in myopia control, treatment, correction and control, even for children. You can start giving from 6 years onwards. This is basically an RGP lens. It's a hard lens. Generally, when you give a contact lens for correction, what you do is you will go, it should be steeper than the steep cornea. But this orthokeratology basically is flatter than the steep cornea, so that it causes steepening of the, it causes flattening of the, cornea of the eyeball. So it has the reverse geometry. It is opposite the geometry design of the normal RGP lens. So it has a base curve, it has a reverse curve, and then it has a peripheral and an alignment curve. When you wear this so you have to recommend the child to wear this overnight for at least 8 hours. The eyes have to be closed with the contact lenses. And morning, after you remove the contact lenses, because of the compression that it has caused, the axial length has reduced and you will have clear vision. So that is about correcting with orthokeratology. I'll also show you how it controls the, peripheral hyperopic focus. So here, orthokeratology, you can start from minus 0.5, and usually we give up to 6 diopters and up to about 1.52 diopters of cylinder, but it is also available with up to minus 11.75 here and 3.5 cylinder of astigmatism. How does it cause the control of myopia? Correction, we know, because of the compression, the axial length has reduced, but control is the same as the myopia control glasses. In fact, this orthokeratology was, prevalent many decades back, even before the control glasses came into vogue. And this also works on the principle of peripheral relative myopia rather than peripheral relative hyperopia, as you can see in this picture. Adopting this concept of the peripheral relative myopia is what myopia control glasses are being done these days. And if you see a topography, this is a classical, perfect, ideal topography map post orthokeratology treatment. So orthokeratology is a temporary way to treat or correct the myopia. So it has to be worn every day and every night, in fact, and removed during the daytime. And daytime, there's no need to wear any other correction. The effect lasts till the next night, and the effect will gradually keep becoming better in a few weeks. Low dose atropine, we all know about this. The classical dose that is available is 0.01%. And now in India, 0.05% also has been introduced. Actually, you have various doses, outside of India. So 0.01, 0.025 is there, 0.05, 0.125, 0.5 and 1%. All these concentrations are available. Even 1% atropine is still being used for myopia control for very refractory cases. In fact, the ATOM-1 study had also used the 1% atropine, but that is very rarely used, but still being used. What are some of the tips, before giving low-dose atropine? Always look for esophoria for near and lag and treat it without looking for treating a lag or esophoria. If you give a low-dose atropine, there is a chance that you're going to aggravate the esophoria and increase the, risk of myopia progression rather than a control. So that is something that you have to look into. Supposing the child has an esophoria or lag, you give a bifocal or progressive and add on the atropine, but don't give atropine without treating this. Second, always be cautious about children who have, ocular allergy, because it's going to be for many years, low-dose atropine. And for those who have neurological problems, developmental delay, and then those who have Down syndrome and all that, it's preferable not to start on low-dose atropine. And this is something that can be started even on pre-myopes. The LAMP2 study has, studied its effect on the pre-myopes, and it's showing good promise. And of course, the dose is 0.02. And onset of action itself is 1 year only. So the minimum dose duration of atropine should be for 1 year. There's no point in giving atropine for few weeks or few months. The onset of action is 1 year, so you give minimum for 1 year and you can go maximum till the child is able to tolerate. Initially, we were following this of giving for 2 years, then giving a break of 1 year and then again 2 years. But that was basically, done following the ATOM study. But that was done for the study purpose. It is not, you need to, stop after 2 years. You can continue if the child is, good on atropine. There's no need to stop the atropine. When you're trying to stop, when do you try to stop? When the child reaches 12 to 13 years of age and kind of axial stability, has happened. I'll come on to how you will look into the axial and stability and all that. You can always taper and stop, but tapering should happen over 1.5 years of age and not a blunt taper. Like something like 6 times. So you give this every day, every night, basically. First you give as every night. And if the child has shown some response, but not a full response, then you make it twice a day. Child is still not shown enough of response, then you go to the next concentration, 0.05 once a day and then twice a day. So you can go like that. So when you're tapering also, what you can do is you can make it 6 times a week for 3 months, then 5 times per week for 3 months, 4 times a week for 3 months, 3 times a week for 3 months, 2 times a week for 3 months, and 1 time a week for 3 months, which will be around 1.5 years. You can try to start tapering a child on atropine around 12 to 13 years of age, provided they are not going to have, something like their board exams and all, wherein they're going to have more reading to do. And then that time we usually see a progression of myopia even at that age, after the 10th standard and the 12th standard. So if they've been very stable and they don't have much of, near work requirement, you can try to start tapering, but over 1.5 years. We have a child, how do we approach the child in terms of controlling the myopia? I think there are a lot of optometrists here. Please listen to this carefully. I don't think we are following all this. This is very important for any child, just not for a myopic child. So always check the distance and near vision. Near vision is very, very important. And do the cover test, like for distance and near. Like I told you, any esophoria, exophoria needs correction because binocular vision anomalies have to be corrected as a part of myopia control. And look for history of parental myopia, prematurity, how much of outdoor sunlight activities there, near work, any developmental delays, seizures, Down syndrome and all that. These questions will tell you about the risk factor for myopia and, also tell you about the contraindications to some kind of management. And first visit, always do a cyclorefraction. Don't go with the T+, at least in the first visit. I usually do wide refraction for children less than 7 years of age and cycloplegic refraction up to about 14, 15 years of age. But when you're giving cycloplegic refraction, you should make sure the child doesn't have history of seizures or any neurological problem, because the cyclopentolate can cross the blood-brain barrier and cause some neurological problems. And homide is best avoided in Down syndrome. So if there are no contraindications, go for the cycloplegic refraction. And then you get a good retinoscopy or an autorefraction. If you have an autorefraction of plus 0.75 and the child is only less than 11 years of age, generally you can categorize the child as a pre-myope. So for pre-myopes, lifestyle modification is going to work wonders. So lifestyle modification should be stressed. And of course, now with a lot of studies that have come, Stellest glasses as well as low dose atropine 0.01 or 0.02, in fact, has been, they've begun to give these modalities for pre-myopes with high risk factors like high parental myopia, very bad lifestyle, visual lifestyle. So that is about the plus 0.75, which is a pre-myopia category. So supposing you do the refraction and you get more than or equal to minus 0.5, that is when you qualify the child to have myopia. In more than or equal to 0.05, if the child is still less than 6 diopters, do the axial length and topography and establish an axial myopia first. So sometimes even because of the corneal curvature being more, you can have a myopic astigmatism and myopia as a component of that. But it's very, very important to establish an axial myopia, which is what we are trying to control. So if it's an axial myopia, your option could be anything. It could be a single vision. It could be a myopia control. Of course, glasses versus contact lenses is something that is up to the parents and the child's requirement. If the child is always outdoor and a child has to have glass independence, and all that, you can go for orthokeratology or contact lenses itself. But the option is generally otherwise only related to the child's requirement. But there are some special situations. Supposing you have anisometropes, and children in sports and all that, you can straight away tell them for orthokeratology. Also, you can suggest orthokeratology also. And one other lens that can be used in anisometropes is Telest. Otherwise, you just give them the single vision class. Whether you given the single vision or a myopia control, you follow them up in 6 months. But here, I usually call the child in 3 months to make sure they're comfortable. The vision is distance and near vision is full. There is no amblyopia and there are no binocular vision problems. Supposing at 3 months, I see amblyopia, the vision is not improved fully, or I see some binocular vision anomaly, I treat it first. And then I start going for the myopia control measure. Usually 6, 9 and better, you can start off myopia control measure also. That follow-up in 6 months, supposing the spherical equivalent is more than it has increased to more than 0.5 diopters in a year, or 0.75 diopters 0.5 diopters in 6 months, or 0.75 diopters in a year. Then along with whatever they're already wearing, whether it's a control glass or a control option or a single vision, you may try to start off the low dose atropine 0.01 first with nighttime dose. And then you see them for 2 years with the low dose atropine, and then try to combine with another thing or make the single dose of atropine into twice. And then that is the first thing about first visit and all that. So it's preferable to see them in 6 months for myopia progression and 3 months to treat amblyopia and the binocular vision problems. At your first visit itself, the myopia is greater than 7 years of age and the child is less than 4 years of age. This is not a normal, school myopia combination. So always try to rule out syndromic myopias, which can be, the connective tissue disorders like because of subluxation of the lens or microspherophakia, all the sticklers and Marfan's and Ehlers-Danlos, all those things have to be ruled out by sending the child to a pediatrician. If it's a very, very young child, you may also have to rule out the possibility of an increased IOP, which will be shown as an increase in axial length. And of course, if the myopia is going on increasing, but the vision is not, improving for the child despite good compliance and all that, always look into the possibility of inherited retinal disorders. So the child is more than 4 years of age. Again, like the other group, you just have to do the axial length and topography and follow up. We spoke about spherical equivalent as 0.5 for 6 months and more than 0.75 in a year. With regards to axial length, if the child is more than 9 years of age, an axial length increase of 0.15 in a year is permissible. It is not progression. So if you're seeing at 6 months, it's less than, it's just the half of this, which is 0.07. And if you're seeing a child who's less than 9 years of age and in 1 year, the increase in the axial length is more than or equal to 0.3, then it's a progression. In 6 months, if it's more than or equal to 0.15, it is a progression. If you have progression, again, like the other group, you may start off, supposing the child is wearing a single vision, start a myopia control. The child is already wearing a myopia control, add on the atropine. Right, this is again what I told you. So you may also have to categorize the child, a stable myopia, a moderately progressing myopia, or a rapidly progressing myopia. When do you actually think about giving a combination therapy, which is actually a dual focus contact lens with the low dose atropine, myopia control with low dose atropine, ortho-K with low dose atropine, myopia control with ortho-K, or dual focus contact lens with control glasses? One is when the child has a very high, risk profile of a high myopia, in fact, or if the parents are very proactive, or if there is continued progression, like I told you, despite the monotherapy. So who is a high risk myope? One is a child who's very young, less than 5 years of onset of myopia, which is the earlier onset, and presenting with a moderate amount of myopia in the beginning itself. Like they start with like 4 diopters of myopia to begin with itself, or they have a long baseline axial length. The first axial length itself is very long, and they have a very strong family history of myopia, or they are East Asian, like India is East Asian, and if they have been on some control measure and they keep progressing despite all that, or their lifestyle is going to be very poor, they're always indoors and not having outdoor this thing, you can always start off a combination therapy for them. Any high myopia, at 5 diopters at baseline or more than 26 mm of axial length at the baseline at the first visit needs an aggressive therapy. So probably those kids, you can start off a combination therapy. Also, children who are rapid progressors are those who have a spherical equivalent change of 1 diopter in a year or 0.4 mm of axial length in 12 months, right? Continue therapy, all these children, you can probably give the combination therapy. So this is like the flow chart of how you can approach a myopia child for giving the control measure. This is what I've already broken up and then explained to you. That's it from my side. I think now we will take up the questions. Another 10 minutes maybe. If we have optometrists and other people practicing, seeing a lot of pediatric children, pediatric patients, I think we are open to answer your questions. So you can just ask also. Let me take up the questions that you've already asked.
So, Dr. Akshaya and Dr. Padma Priya, wonderful presentation by both of you. I would
Yes, ma'am.
suggest you to just look into the questions which have been answered in the talk itself and answer those which have not been addressed. So, couple of
Sure.
questions I think we have answered during the talk itself, and
Hmm.
couple needs some discussion. Please look into that and then address it accordingly.
Yeah, atropine, someone has asked from which age to start. Oh, it's already been answered. Dr. Padma, would you like to take up some questions? Already Dr. Padma has answered questions in the
Yeah, I've
chat.
been answering a few, and yes,
I
there
think
is one.
probably we will just start playing the chat questions also. So there's someone who's asked, do you do cycloplegic refraction for each visit? Generally, cycloplegic refraction in the baseline visit is very, very important because there is a big chunk of pseudomyopia that we are seeing. Children who have plus number actually are only by subjective refraction, they give minus and they start even control measure. Baseline cycloplegic refraction is very important, and a yearly or in our present scenario, at least 2 yearly. Once we've established, we know the trend of the child's progression, we can probably go ahead with T plus. We are good to go with that. But first, the baseline is important. Also, if the vision is less than 6/9 and there is more than 0.75 diopter change in 6 months or 6 months, you could probably again put a cycloplegic refraction to check. There is no need to keep checking every visit, but baseline cycloplegia is very important. Homide better than cyclopentolate for less than 7 is what I prefer, because it is safer and it has a little more better cycloplegic than cyclopentolate for kids younger than 7. That is what I prefer. And if there is a contraindication for cyclopentolate, we'll have to go ahead with homide. Is it essential to document progression in axial length before starting atropine? According to me, yes, because myopia management has, like we have been repeatedly telling, we have two aspects. One is correction. Correction is by way of the optical means. Control is by way of seeing the axial length only. Correction, basically using the refractive, the spherical equivalent or the refraction per se. And control is based on the axial length. So I would always want to measure the axial length, look for the progression, and continue. Guide that which will guide my myopia control management. Axial length is very important for me. Dr. Padma, do you differ? I think you said axial length is not mandatory. If you have your thoughts, you
That
can.
is what it's been given. The consensus is in that way, like it is not mandatory, but it is helps a lot if we can document axial length, so that we can note for any progression. So it is basically more for a documentation, because axial length progression and the spherical power change, they go hand in hand. So yes, it is not mandatory, but it is essential. I would draw that line.
Yeah, because there is a category of people who have very flat corneas, and so the refractive error is very low, even plano. But you see their axial length is very long. But what we are trying to control is the axial length. So I would always, for any child, even for a pre-myope, do the axial length, look at the trend in axial length progression, and then start my myopia control accordingly. And if progression despite atropine, do we increase the frequency or strength? You've been using a 0.01 HS nighttime, you can make it twice a day, or you can go to the next, dose of atropine. But I prefer seeing at least for a year, because the peak action of atropine itself comes around 1 year only. The next question is, myopia correction up to what age we can undercorrect? Please do not undercorrect myopia on purpose. Even if you want the child to have the same glasses, supposing you see a small change in the glass number, child is already wearing a control glass, you don't want to change it so quickly. If the child is not having any binocular vision problem because of the undercorrection, then you leave it. But otherwise, there is no question of undercorrecting myopia at all. Hyperopia and astigmatism, irrespective of age, do we give full correction? No. So I would like to say a little bit about the hyperopia correction here. For hyperopia correction, you have some things that are very important. One is the cover test. If you have an esophoria in cover test, try to push the plus so that they become ortho. Basically, esophoria for near. And if they have an esotropia, there's no question. You have to do a cycloplegic refraction, preferably atropine, and give the full correction. But you need not give full hyperopic correction in esophores. You can try to just push the plus. Pushing the plus is by doing fogging or by doing something called a Borish delay test, which is again arresting your accommodation and doing. And whenever you do a hyperopia, I mean correction for hyperopia, I recommend doing the near point of accommodation monocularly and the near point of convergence. If you have a near point of accommodation that is receded, it means that the child is requiring a plus. So you can try to push the plus. And one more thing about hyperopia correction is the age. If the age is less than 7 years, you can undercorrect according to the age. But you have to give a little bit of hyperopia for that age, because that is important for the normal hematropization. And astigmatism, make sure you do a proper retinoscopy or a good AR and just give the full, astigmatism correction, because at the first go, they will not read fully, but with the full correction, they will, the vision will start improving. Because in astigmatism, the basic is to completely break that conoid of stem and push it on the retina. Because in that interval of stem, in whichever power you're going to give, they are going to read. But that's not the purpose of correcting astigmatism correctly. You have to break it. So which means you have to give the exact full astigmatism correction. Even for adults, I prefer doing that. Indications for PMT, when one thing is the pseudomyopia, when your acceptance is minus, but you do a T plus or a cycloplegic, you have a plus. So it's a big variation. So you have to call for PMT. Of course, if you've done an atropine refraction, after 21 days, you can call for PMT. PMT in very small children actually, to me, doesn't make that much of sense rather than an objective. So objective refraction is much, much better in children. You do a proper retinoscopy or a proper AR and give the proper objective value. And then you call them back to check the vision after 3 months of wearing the glasses properly. Because PMT is again going to be a subjective measure.
If I may, there is one question like, so do we repeat axial length after 6 months? And if progressing, then only we start atropine. And in high myopia at presentation with myopic fundus, it's obviously axial. So then can we start at presentation? So this is a question that is being posted.
Yes. Do you want to take it up, Dr. Priya, or should I do it?
See, if there are no associated risk factors like age of onset, genetic factors, if they are all okay and the myopia is of a lesser power, then I would ideally wait for another 6 months, see if there is a progression, and then start the child if it is the first time wearer, and then start the child on myopia control measures. So that is for the answer for the first question. And the second one is in high myopia at presentation with myopic fundus. So just a myopic fundus alone doesn't mean that it is an axial myopia. In this particular case, we have to take into account the axial length, and then we need to document it that it is an axial myopia. And considering the age and other parameters, then we can start at presentation. Suppose say if it is a 4-year-old child coming to a 6-year-old child coming to us with say around -2 diopter of myopia, and the axial length is say around 24 or 25, which is more for that particular age, yes, then it is very well within limits to give the glasses and start the myopia control then and there, probably a myopic defocus glasses or a atropine drops. So this is warranted in such cases. So that is my answer.
Sure. To simply remember it, at 18 years of age, make sure the axial length is not more than 26 and try maximum to have, control the myopia up to 3 diopters. But in this present scenario, this is being very difficult, at least 5 diopters. So you take a call according to the age and the axial length and the refractive error at presentation. Also, there is an entity called congenital myopia, which will have high myopia in a very small age, like 4 5 year of age with 10 diopter myopia. For that, it's because congenital myopias do not progress. So for that, maybe you can look for a progression for 6 months or 1 year and then start atropine. And one more thing about myopia, correction itself, lot of high myopes, like more than 6 diopters in very small children may require add. If they have only an N8 or something or reading N6 very close to face, try with a little add and see. If they have an add, please give the add. It also corrects their lag because high myopes do have, and very small children have this lag of accommodation also. And one more thing is when Dr. Padma was talking about amblyopia, even in amblyopes, there is a lag of accommodation. Whenever you see any child with an N8, N10, please put a plus, 2 or +3 and check the near vision. This is for the optometrist. So there are a lot of situations apart from just presbyopia, which will require a separate add. Two such situations are high myopia and amblyopia. And other things are, child with a developmental delay, CBI, all those things. So that is something you should remember. There's one question. Would you recommend ortho-K for pediatric patients? How can infection-related complications? Ortho-K for pediatric patients from 6 years of age for myopia control is actually the trend now because it's very effective in the control of myopia, and these lenses are worn only during night. They are specifically designed for nighttime wear, and they're not wearing during the daytime, and they're not exposed to any environmental, infection or anything like that during daytime. They're going to remove it off as soon as they wake up. And these are high decay. There's no, real worry. And they are RGB, and there's no real worry about the hypoxia or anything of the cornea. So it is definitely recommended. It is going to be the thing because that is going to be the most effective way to correct and control myopia. Otherwise, all children are going to end up with like very thick glasses present this thing that we are seeing. So yes, we recommend ortho-K for pediatric population from 6 years of age onwards, and provided they are really motivated. Compared to the normal daytime contact lens, the infection-related complications in ortho-K is pretty much less only, like because they are not exposed to anything during daytime with the contact lenses on. Do you do retinoscopy to confirm the measurements? Use auto ref portable, please. I do the retinoscopy to confirm the auto ref because, of course, we all know that there is an overestimation of hyperopia with AR, and maybe a little underestimation with of myopia. So I always recheck with the retinoscopy. But if you have a good reliable auto ref, I mean it's a good one, then well calibrated, then you can use your auto ref itself as a guide. I have two patients, both now 13 years old, and we started atropine drops 3 years ago. Both respond very well. One patient we start tapering off, and okay. So 13-year-old, I just need to know if the ethnicity of the child, whether the child had some near work post, tapering the atropine, and what dose of concentration of atropine was used, and how was the tapering done.
So there is one which asks like till which age, please, you give high difference axial anisometropia for a child? Do you document axial anisometropia by axial length measurement?
Yeah, so anisometropia should be fully corrected in children. There will be no diplopia in children, definitely. So even if it's a plano and a -10, please give the plano and the -10 without, trying to balance or anything, because we're talking about the development of vision in the child. There is no question of diplopia here. They will not have diplopia. So all axial anisometropias should go in for full correction. And yes, axial length measurement difference should be noted, because if the higher refractive error eye is showing progression, it also means that the other eye is going to show progression. Usually it's like that. When one eye is tending to progress, the other eye also tends to progress because it is having the same risk factors. So it is important to document the progression and start off the control measures for both eyes. What is the cost?
Cost? I assume it is for ortho-K, whom to connect, and if lens falls, how to instruct parents.
Okay.
So cost is somewhere around 30 to 40,000, I assume. Now, currently we have one model in India, so that is
Paragon.
Paragon lenses, CRT lenses. It is being done at CMH very well. So please feel free to contact Dr. Akshya or the optometrist department at CMH for orthokeratology. And if the lens falls, that is a very rare circumstances because these are to be worn only during sleep time. So there is a very less probability that the lens might fall. If at all
Ma'am,
there
can I
any.
answer?
Yes.
Sure, Harish.
Yeah. So the lens falling will not be happening. The lens may move inside the eye out of the cornea. And secondly, so while using or wearing the lens, generally we ask them to keep a white in a place wherein they can track the lens if it falls. Lens being lost in case of orthokeratology doesn't happen. Lens breakage may happen due to mishandling.
Sure. Thank
So
you.
I have just mentioned the contact numbers for OrthoK, myself and Mr. Harish, who's the chief optometrist who just spoke. So you can contact any of us for the orthokeratology. And in fact, children who are like more than 10 years of age, 10 to 14 years of age, they are really loving it because there is no need to wear glasses or contact lenses during the daytime. It's a good option for those who are in, sports and dance and swimming and other things, or even otherwise. And apart from that, it provides excellent control of myopia. You can feel free to contact any of us for OrthoK.
And there is one more question. Could you recommend an excellent ARK for pediatric patients? Say
Autorefracted keratometry, right? ARK, if that's right. Mr. Harish, if you can guide him, please. There's someone who wants to know about.
So I think there are a lot of instruments, but for pediatric refraction, any of the autorefractors, I would not give too much of weightage. So it is better that we do practice retinoscopy so that we are able to get a much better results. Having said that, Topcon as well as Nikon and these two instruments, they are giving pretty good results. Again, their models will be different. So you need to take a look at few patients, then only you can finalize.
So considering pediatric patients, it might be difficult to make them place their chin and look into an object into the AR machine. So if that is the concern, then I would suggest going in for a vision screener also. So there are pediatric vision screeners available, so which give you a rough value of what the refractive error could be likely in that particular patient. That is, it can just only highlight. So based on which a proper retinoscopy can be done, and then a prescription can be given. So you don't have to place the child, it is placed far apart from the child and it screens the eye for any refractive error. So you can Google it up to see pediatric vision screeners, and they might help in pediatric cases.
Okay. On that note, we can also do the Bruckner's test, which is more simple and available to us. I think using a direct ophthalmoscope, you just have to sit at 1 meter and show the light, and you observe the reflex from both the eyes. So if you have a crescent that is brighter superiorly, it means it's an uncorrected or undercorrected hypermetropia after dilatation. And then if you have a lower crescent, it means that it's an uncorrected or undercorrected myopia. And if you have a difference in the, level of glow, level of brightness, it could either mean a squint or it could mean an anisometropia, which is a very, very basic, simple guide as to whether there will be a refractive error in a very small child, which is the reason for anything else like a squint or anything. And you also have handheld ARs now, autorefractometers for very small children. Like the handheld keratometry, there's also a handheld autorefractometer. We could probably find out and put it in the comments.
For the want of time, I think we can just give a short take home messages and then we can wind up the session. And all the rest of the questions which have been, I think most of the questions have been answered, and rest of the questions which are there in the mind of our attendees can be passed over to edu@dragarwal.com, and we'll make sure that those are answered. So I think we can wind up the session with some take home messages from Dr. Padma and Dr. Akshya.
My take home message is, like as I've already presented, do not rely on what the child says, rather go by what your objective verification is. Can always cross verify it. We can do an AR, we can do a retinoscope, and then give a prescription to the child. not just only checking for the glass power, but also look into the compliance, how comfortable the child is wearing the glasses, is the child wearing the glasses regularly, and also look into the frame and the lenses also. Do ask them to come for a frequent review regularly. As a general, for any normal child, a regular ophthalmic checkup will be 6 monthly. Suppose if the child is amblyopic and you want to see the child, then it is based on your discretion. If at all there is any doubts or queries, always here to help you out. Thank you. And thank you for the opportunity.
So my take home message will be like, again and again, I've been telling all the optometrists, please include binocular vision assessment as a part of your refractive correction. Cover test is very, very important, NPA, NPC. And objective refraction for a child is the thing. There is no need to do subjective refraction. Concentrate on the objective refraction and the cover test to prescribe any refractive error in children. And as far as myopia control is concerned, keep the correction and the control separately, but do that together, meaning glasses or contact lenses for correction, also keep the axial length for control. So both the aspects have to be dealt with simultaneously, because we are seeing a lot of, myopia from a very young age. We are going to see children ending up with very high myopia. So it's very important to be proactive. We are looking at correcting or starting control measures for pre-myopes themselves. I think if you have an access to axial length, you should do it for every child, despite the refractive error. That will be my take-home message. Thank you so much. I've put in my number there. You can contact me anytime.
And one more I would like to add, just not giving them spectacles, do advise them on lifestyle modifications, like to put their phones down and look up and go out and play, have a lots of outdoor activities with plenty of sunlight. So that helps them in a long way, not just only for ocular related issues, but for other psychological and issues also. Let's all support the children in their growth. Thank you.
Thank you all. Thank you, ma'am.
Thank you so much, Dr. Akshya and Dr. Padma. It was a really, really eye-opening and a wonderful presentation. All the very best.